One of the interesting results from the CAT and the IVAN trials uh, was they looked at the incidence of atrophy during 2 years of therapy with anti-VEGF treatment using either bevacizumab or ranibizumab. And they both found that after 2 years, there was an increase in the risk of the development of atrophy in the study eyes, about an 18% incidence in the CAT trial and about a 30% incidence in the IVAN trial. And when the investigators looked at the risk factors for developing atrophy, they found that receiving monthly injections rather than PRN injections seemed to be associated with an increased risk. They also found that the presence of atrophy in the fellow eye or the presence of intraretinal fluid seemed to be associated with an increased risk. One of the surprising findings was that the presence of subretinal fluid seemed to be associated with a decreased risk of developing macular atrophy. And that's difficult for me, at least, to understand because we treat with the anti-VEGF agents in order to eliminate the fluid, thinking that this will be beneficial for our patients. Now, fortunately, in both of these trials, the development of macular atrophy was not associated with the loss of vision. But of course, we could speculate that if the patients had been followed longer, eventually the atrophy would be associated with visual loss. Well, following those two trials, the Harbor trial was done, and that was also a multi-center prospective randomized phase 3 clinical trial. The purpose of Harbor was to look at two different doses of ranibizumab, zero point 0.5 milligrams and 2 milligrams, using two different treatment posologies, one PRN treatment, the other monthly treatment for each dose. And they found very similar results, which was that there was an increased risk of developing macular atrophy that was independent of the dose of ranibizumab. And that in addition, during the time of the study, the development of macular atrophy was not associated with loss of vision. The Harbor trial also found that there were risk factors for developing macular atrophy, which are same as the ones found in IVAN and CAT, such as the presence of intraretinal cysts, atrophy in the fellow eye, increased patient age. But interestingly, they also found that subretinal fluid was associated with a reduced risk of macular atrophy. And in fact, Dr. Sada and his colleagues looked at this issue in detail, and they found that when analyzing the Harbor data post hoc, the risk factors for developing macular atrophy were not the dose of ranibizumab, but the presence of atrophy in the fellow eye, the presence of intraretinal cysts, older patient age, and subretinal fluid, once again, was protective against the development of macular atrophy. Now, I want to emphasize that this subretinal fluid is treatment-resistant subretinal fluid. The investigators were trying to make the fluid go away, but it was there despite aggressive therapy. So we asked whether the amount of subretinal fluid could possibly be associated with an increased or decreased risk of developing macular atrophy using the Harbor data set. And so we divided the amount of subretinal fluid into increments, starting with no subretinal fluid or greater than some all the way up to 50, or 51 to 100 microns, or greater than 100 microns thickness of subretinal fluid. Again, using the Harbor data set. And again, I want to emphasize this is treatment-resistant subretinal fluid. And of course, this is a post hoc analysis, and we combined all the treatment arms to pool them, giving us 785 eyes to study. And we looked at three outcomes. First, the presence and thickness of the subretinal fluid, which was evaluated using SDOCT. Second was the best corrected visual acuity, which was assessed using standard ETDRS protocols. And third was the presence of macular atrophy, which was determined from colored fundus photographs and fluorescein angiograms by masked graders. And of course, subretinal fluid was defined as exudate occurring between the photoreceptors and the RPE layers. And these conclusions were determined by looking at all the B scans for each patient. There were two masked graders, with a third grader adjudicating any discrepancies between the two graders, if they arose. The atrophy was defined as sharply demarcated areas of RPE depigmentation with increased visibility of the choroidal vessels through the lesion, and they had to have a minimum diameter of 250 microns in order to count as atrophy. And we included all the atrophy that was immediately within, adjacent to, and even not adjacent to the choroidal vessels, whether they were active or regressed. Now, the first finding we had was that the ranibizumab-treated eyes with residual subretinal fluid had greater mean best-corrected vision than the eyes with no subretinal fluid, regardless of the subretinal fluid thickness. So if we looked at the mean best-corrected vision as a function of the subretinal fluid status, the patients that had any subretinal fluid, including those that had more than 100 microns thick subretinal fluid, had better vision at month 12 than the patients that had no subretinal fluid at month 12. And this difference was statistically significant at the 5% level. And we found the same result at month 24. Now, if we ask a slightly different question, which is the change in vision from baseline, it turns out that, as was found previously, the subretinal fluid status was not associated with a superior or inferior change in best corrected vision from baseline. So in other words, the change in best corrected vision for those patients that had no subretinal fluid was around 10 letters. And the change for patients that had some subretinal fluid, any subretinal fluid, ranged between 9 and 12 letters. And these differences were not statistically significant, neither at month 12 nor at month 24. But what was significant was the risk of developing macular atrophy. So if we looked at patients that had no subretinal fluid by month 3, and let me just remind you, all the patients that we included had subretinal fluid either at the screening exam or at the week 1 exam. They all had subretinal fluid to begin with, but nobody had macular atrophy. And if we look at the patients who, after their 3 monthly doses, had no subretinal fluid in month 3 and compare those to the patients that had persistent subretinal fluid at month 3, by month 12, the ones with no subretinal fluid at month 3 had a 26% incidence of macular atrophy, whereas the patients that had residual subretinal fluid only had a 5% incidence. And this difference was highly significant with the p-value less than 10 to the minus fourth. If we looked at month 24 comparing these two cohorts, the incidence of macular atrophy was 36% among those that had no subretinal fluid at month 3, as opposed to 13% among those that had subretinal fluid at month 3. So the difference persisted. If we did a slightly different analysis and said, what about the outcome of patients that had no subretinal fluid by month 6 versus those that had persistent subretinal fluid by month 6, what we found is that if we look at month 12, the patients that had no fluid at month 6 had, again, about a 26% incidence of macular atrophy as compared to a 6% incidence of macular atrophy among the patients that had subretinal fluid at month 6. And similarly, if we looked out at month 24 and compared these two cohorts, the patients with no fluid at month 6 had a 36% incidence of macular atrophy, as opposed to the patients that had fluid at month 6, who had an 11% incidence of macular atrophy. So clearly, having subretinal fluid at month 3 or month 6 that was treatment resistant was associated with a very substantially lower risk of developing macular atrophy. Now, how to interpret these data? There are many ways we could. It could, for example, be that we were just looking at an asymmetric process and the macular atrophy was developing naturally, but faster in one group than another. That seems the least likely explanation. Another possibility is that there's something inherently different about the patients that have persistent subretinal fluid despite treatment, something different about their propensity to develop macular atrophy, and that this subretinal fluid status is really a biomarker, but not directly related to any kind of protective effect of the patient. But another way to look at the outcome is as follows. If we hypothesize or speculate that the changes in the RPE and the choriocapillaris and Brooks membrane in age-related macular degeneration in some way lead to impaired oxygen transport to the photoreceptors, and if that hypoxia in turn leads to the increased expression of vascular endothelial growth factor, and if that in turn leads to the development of choroidal neovascularization, well, then, of course, that's the way we can understand the presence of subretinal fluid associated with choroidal new vessels, because we know that VEGF is associated with breakdown of the integrity of the tight junctions in the endothelial cells. But we could look at this whole sequence of events as a homeostatic response to hypoxia. And so we could look at the subretinal fluid as potentially being a manifestation of an imperfect but critical survival mechanism for the degenerating macula. And in the presence of treatment-resistant subretinal fluid, what we would then have is a transudate rather than an exudate, because the VEGF-A does restore, to some degree, the tight junctions of the endothelial cells. And the biochemical composition of a transudate is probably different from an exudate, and it's probably closer to what the photoreceptors are normally accustomed to seeing. So perhaps treatment-resistant subretinal fluid is an example of a situation where we achieve the goal of increased oxygen delivery through the presence of the subretinal new vessels, but we also manage to preserve a more or less normal extracellular milieu, so that the photoreceptors are not particularly damaged by the presence of the subretinal fluid in that case. Pure speculation. But on the other hand, to continue this speculation, if it turns out that the treatment or through some other mechanism, the perfusion through the choroidal new vessel is really shut down, with the result that we have no fluid whatsoever, that could perhaps be associated with a degree of hypoxia. And if it is, it would then be easy to understand why the absence of any subretinal fluid is associated with an increased risk of developing macular atrophy. Because essentially then the absence of subretinal fluid would indicate that this imperfect survival mechanism has been terminated, and macular atrophy is now going to develop, which is what would have happened if the vessels had not grown to begin with. So in summary, we analyzed subretinal fluid in 50 micron increments and found no threshold that was detrimental to vision outcome over 2 years in this post hoc analysis of the Harbor data. The rates of macular atrophy were significantly higher in the absence of treatment-resistant subretinal fluid. And these findings are consistent with earlier analyses by a number of investigators who've suggested that the mere presence of subfoveal choroidal new vessels that are not leaking is associated with impairment of the spread of macular atrophy. And so as a result of all this information, we believe that persistent subretinal fluid in the course of aggressive anti-VEGF therapy might be a sign of persistent choroidal new vessel perfusion with transudation, which might operate as an imperfect compensatory mechanism that maintains the function of the degenerating macula. Thank you for your attention.